Good evening, everyone, and welcome to our presentation on steroid-responsive meningitis, arteritis, and other inflammatory neurological disorders of dogs. Clearly a topic of great concern to quite a lot of dog owners, breeders, trainers, and veterinary caregivers, everyone joining here this evening. My name is Dr. Sherry Berger, and I am pleased to be serving as your host and moderator on behalf of VetVine this evening. All of these programs have been made possible with the generous support of our wonderful partner in the series, the AKC Canine Health Foundation. And we thank CHF not only for their support of this educational program, but for all that they do on behalf of canines and in funding important research with the intent of helping our dogs live longer, healthier, and happier lives, including research that will be discussed tonight. And so with that, I'd like to introduce a special guest that's joining us this evening on behalf of the Foundation. I'm pleased to welcome back Andrea Fiamefredo, who is the Director of Programs at the AKC Canine Health Foundation. Andrea oversees the Foundation's research and educational programs, and she's here with us this evening to share a few words with you, our audience. So, Andrea, welcome. I'm so glad you can be here with us this evening.
Thank you, Dr. Berger. I'm very happy to be here as well. On behalf of the AKC Canine Health Foundation, I'd like to welcome everyone to this presentation on SRMA and other inflammatory neurological disorders. We are very pleased to sponsor Dr. Manana's discussion on diagnosis, treatment, and management of these disorders. The Canine Health Foundation has supported work with Dr. Manana in a number of studies in our pursuit of the important mission to help prevent, treat, and cure canine disease and health concerns through research. Thank you again to VetVine for this partnership and to Dr. Manana for what we're about to learn.
Great. Thank you, Andrea, and again to everyone at the Foundation for helping to make this evening possible. So it's now my pleasure to introduce our presenter this evening and a distinguished colleague, Dr. Karen Manana. Dr. Manana is a board-certified specialist and a diplomate of the American College of Veterinary Internal Medicine in the subspecialty of neurology. Dr. Manana is a professor of neurology at North Carolina State University's College of Veterinary Medicine, where she's been on faculty since 1994. Dr. Manana has authored over 80 papers and book chapters on topics pertaining to veterinary neurology and her research interest in canine epilepsy, and we learned about some of her work in this area in a previous webinar. Her research frequently involves clinical trials in which new treatments or diagnostic tools are evaluated in the context of neurological disorders. Again, I'm so grateful that she accepted the invitation to return to our event space to share her knowledge with us on tonight's topic, SRMA and other inflammatory neurological disorders of dogs. So with that, Dr. Manana, I say welcome, and the floor is now yours.
Thank you, Dr. Berger. I'm very pleased to be with you tonight with this webinar. So as Dr. Berger said, the topic of this seminar is inflammatory disorders of the central nervous system of dogs, with a particular emphasis on steroid-responsive meningitis, arteritis. And it has a general outline. What I hope to accomplish is to provide you an overview of inflammatory conditions of the central nervous system in general. And I will spend a little bit of time talking about the most common inflammatory central nervous system we see in dogs, called meningoencephalitis of unknown etiology, or MUE. The focus of the presentation, the predominant disease I'll talk about, is steroid-responsive meningitis, arteritis. And we will discuss the clinical signs, method of diagnosis, treatment, and then expected outcome with that disorder. So to start just with some general information and definition, so the central nervous system consists of the brain and the spinal cord, and both of those structures are surrounded by a fibrous tissue called the meninges. Beneath the meninges is where the cerebrospinal fluid, or CSF, resides. When we have inflammation of the brain, it is called encephalitis. When we have inflammation of the spinal cord, it is called myelitis. And then inflammation of the meninges is meningitis. And each of those can occur individually or in combination. For example, if we had inflammation of all three elements, it would be called meningoencephalomyelitis. We could also just get a meningoencephalitis or a meningomyelitis as well. With respect to the causes of inflammatory neurologic disease in dogs, we tend to break it into infectious and non-infectious causes. And the infectious causes can be viral infections. The two most common ones, the most significant ones we think about in dogs are canine distemper virus and rabies virus. We can have bacterial infections. Those primary bacterial infections aren't that common in dogs, but we can also see rickettsial infections, things like Ehrlichia and Rocky Mountain spotted fever that can cause encephalitis in dogs. Fungal infections, the prevalence of those diseases varies depending on the area of the country you're in. Protozoal diseases, most commonly we hear about toxoplasmosis, also Neospora, and then lastly parasitic diseases. So those are all diseases that we are concerned about, but in reality infectious causes of inflammatory CNS disease are a very small component of what we deal with in our dog population. And the most common thing that we see, or the most common category of disease that we see, are the non-infectious causes. And this is a group of disorders, but they are believed to be immune-mediated in origin. And these are the disorders, the immune-mediated, non-infectious disorders, is what I'm going to focus on for this presentation. So those non-infectious inflammatory disorders can be broken up into, again, several classes of disorders as well. The most common disease we see, which I mentioned at the beginning of this webinar, is meningoencephalitis of unknown etiology, or MUE. Other disorders that we can recognize are a disease called idiopathic tremor syndrome. It's also called little white shaker disease. We see an eosinophilic meningoencephalitis, which again is just inflammation with a specific type of inflammatory cell in the central nervous system, with the eosinophil being predominant. And then lastly is the steroid-responsive meningitis arteritis, which we will be speaking about shortly. The clinical signs that we see with inflammatory disease of the central nervous system is dependent on the location of the inflammation. With inflammation of the brain or encephalitis, we can see signs such as seizures, behavioral changes. The dogs can have disequilibrium or be incoordinated in their gait. They can have blindness, weakness around their face or head muscles, and altered consciousness. And which one of those signs or a combination of signs we see depends specifically on what area of the brain is involved with the inflammation. The cardinal sign of meningitis is neck pain. Although if we have inflammation of the meninges in the lower part of the spinal cord, an animal may present with neck and back pain or back pain alone. And then finally, if we have inflammation of the spinal cord, depending on the severity, an animal may present with an uncoordinated gait. If it becomes more severe, that animal may show weakness or paralysis of the limbs, and associated with that weakness or paralysis, there can be incontinence as well. Cerebrospinal fluid collection and analysis is the most useful test that we have to diagnose our inflammatory diseases of the central nervous system. The cerebrospinal fluid is a fluid that surrounds and bathes the brain and spinal cord. And in this MRI image that's shown on the right-hand side of the slide, we have an image of the brain in which fluid, the surrounding cerebrospinal fluid, is white. And what I've depicted in that image is where we would place a needle. So to collect cerebrospinal fluid, we insert a small needle into the fluid-filled space where the brain and the spinal cord meet. And in the image below, you can see us actually have a needle in place, and we are collecting the fluid. And the fluid typically is clear and colorless. And we take that fluid and analyze it for the number of cells or presence of inflammatory cells in it, so we can confirm that inflammation is present. We also look at the specific type of cells present, and that can give us some indication as to what sort of cause the inflammation may be due to. Currently, we frequently use MRI as a diagnostic tool for animals with neurologic disease, although I think it is important to remember, at least in my opinion, that cerebrospinal fluid is still the most important diagnostic test that we can do, and approximately 25% of dogs that have inflammatory CSF and evidence of encephalitis or myelitis because of that will have normal findings on MRI. So there are some cases of animals that will have a normal MRI but still have presence of inflammation that can be diagnosed with cerebrospinal fluid analysis. So to discuss a little bit about meningoencephalitis of unknown etiology, it's called MUE. Some other people will call it MUO. So if you hear people referring to MUO, it's actually the same disease. This is, as I mentioned before, the most common cause of encephalitis in dogs. We tend to see it most commonly in young to middle-aged female toy breed dogs, and poodles and terriers seem to be predisposed. The exact cause of MUE is unknown, but it is believed to be immune-mediated in origin. And there's been extensive search for possible triggers, either infectious triggers or environmental triggers, and it's still believed that those may be the case, but an inciting cause has not been identified as of this point. Recently, there has been shown that certain breeds of dogs can have a gene-associated susceptibility. And that was discovered primarily or initially in pugs, and we'll talk a little bit about pug encephalitis. But we do have to remember that when we use the term MUE, we're likely not talking about a single disease process, but rather this is a group of disorders. And another thing that's important to remember is that MUE is what we consider a clinical diagnosis. So we arrive at this diagnosis based on the animal's signalment, meaning, if it is a young female terrier, what sort of clinical signs they show, because MUE can have signs that are more characteristic than other diseases, and the diagnostic findings. And we always want to rule out infectious causes, although, as I alluded to previously, the infectious causes are a relatively small subset of animals that have inflammatory disease of their central nervous system. But MUE has this clinical diagnosis actually encompasses several diseases. And these diseases that it encompasses can only be differentiated and diagnosed definitively with microscopic evaluation of nervous tissue, which would be obtained via a biopsy or in an animal that has passed away from the disease via an autopsy. And the three diseases that we think about that are encompassed in this clinical diagnosis of MUE are granulomatous meningoencephalomyelitis, or GME, and then the necrotizing encephalitides. And there's a necrotizing meningoencephalitis, or NME, which some people will also refer to as pug encephalitis, and then a necrotizing leukoencephalitis, or NLE, which is most common in the Yorkie breed. These images here just show that on MRI, we can see abnormalities with MUE, and we look for characteristic abnormalities in that disease. In the MRI figure in the top, that's a cross-section of a dog's brain, and those white patchy areas are actually areas of inflammation in the brain. The MRI on the bottom, the white area is more diffuse inflammation involving another animal's brain. And then the image in the middle is actually a picture of cerebrospinal fluid obtained from an animal that had MUE. With respect to treatment of MUE, the mainstay of treatment is prednisone and corticosteroids. However, more recently, a lot of other immunosuppressive agents have been used, and they're listed in this table. Those drugs include azathioprine, cyclosporin, cytosine arabicinide or Cytosar, mycophenolate, lefonamide, and lumustine or CCNU. Most of these drugs are given by the oral route. The one exception is Cytosar. And in terms of the frequency of administration, many have to be given on a daily basis. It is important to remember that these drugs are indicated for the disease, but we don't prescribe them lightly because they all are associated with side effects. And the side effects can be on a relatively minor stage and just perhaps an irritant, for instance, an increased appetite or thirst or urination we can see with prednisone, to much more significant side effects such as liver disease or bone marrow suppression, which we can see with some of the other agents. I think it is very important to remember that all immunosuppressive agents, meaning prednisone or any of these other drugs that are listed, are associated with an increased risk of infection because essentially what they do is suppress the immune system and the body's ability to fight off infection. We'll discuss these medications a little bit more as we discuss SRMA. So we have this group of medications that can be used, and a lot of people ask, what's the best choice for treatment? And the answer is, unfortunately, we don't know. And even though we've been using these medications for some time now, and there's some publications on them, it's actually difficult to assess the relative effectiveness of these therapies. And the reason for that is, as I mentioned previously, when we talk about MUE, we're talking about a rather diverse group of disorders. And also the type of studies that we oftentimes have in veterinary medicine are retrospective, where we're looking back at cases as opposed to evaluating on a real-time basis. Oftentimes they haven't been given a control medication, and they're not blinding as to what medication they've given. And when we talk about the value of studies in the literature with respect to scientific studies and their validity with respect to treatment, we think about the quality of evidence. And unfortunately, the quality of evidence that we have for treatment on MUE still is relatively low. Nonetheless, there was, I think, a very valuable paper that came out several years ago that essentially looked at all the data from all the studies that had treated dogs with MUE. And they came up with a total of 457 cases that had been published and analyzed the information from those studies. And based on that evaluation, they concluded that treatments with corticosteroids, in addition to another immunosuppressive agent, may result in prolonged survival compared to treatment with corticosteroids alone. I think probably more importantly is dogs that survive the initial disease phase have a good chance of a prolonged survival. So a lot of times when we talk about MUE and people hear about MUE, they think about it having a rather poor prognosis. And unfortunately, some of those cases do. But if we can get the dog through the initial phase of the disease, then its long-term prognosis is much better. And because we really don't have a lot of basis to make our recommendations on what treatment is most effective, further prospective studies are definitely warranted in this venue. Well, now to switch gears a bit to steroid-responsive meningitis arteritis, which is the brunt of the discussion for this evening. So it is, again, not as common as MUE, but still is a fairly common neurologic disorder that we see. Most of the data on SRMA has come out of Europe, and one recent study out of Europe showed that it's about 1.6% of the neurological referral cases. So this was written in a neurologic referral practice, and between 1 and 2 out of 100 dogs that they saw were diagnosed with SRMA. So particularly for neurologists, a fairly significant disease that we deal with. It is a disease of young dogs. Usually people will say less than 18 to 24 months of age, and we'll talk a bit about that here in a bit. And it is important to remember that it can occur in any breed of dog, but there are definitely breeds with reported predisposition. And the ones that have been published in the literature to date are listed here and include the Beagle, Bernese Mountain Dog, Boxer, the Nova Scotia Duck Trolling Retriever, Weimaraner, Border Collies, English Springer Spaniel, the German Shorthair Pointer, the Jack Russell Terrier, and the Whippet. And the Beagle was the breed that it was described in first, and some people will refer to this as Beagle pain syndrome because of that. The mechanism of disease in SRMA is poorly understood, but as a meningitis, it is characterized by inflammation in the meninges, and in differing from other causes of meningitis, there's also inflammation in the associated vessels in affected animals. This figure I have here is a microscopic section from an animal with meningitis of different cause, but just to illustrate, you can see the arrow pointing to the nervous tissue, the pink nervous tissue. And typically, overlaying the nervous tissue is a thin layer of cells, which includes the meninges. And in this case, or a case with meningitis, you can see that the meninges are expanded with inflammatory cells. And all those little blue, purple dots where the arrows are pointing are actually inflammatory cells that are expanding in the meninges. Similar to MUE, the cause of SRMA is unknown, but it is believed to be immune-mediated in origin. And there has been some proposal that environmental factors might serve as a trigger. And this has been hypothesized based on the specific type of immune response that is present in SRMA, which tends to suggest that there may be some sort of antigen or foreign substance that is triggering this immune response. But to date, no infectious cause has been identified as a potential trigger. Because it appears that there are breeds that are predisposed to it, a genetic tendency has also been proposed, but to date, the genetics of the disease have not been discovered either. There are two forms of SRMA, and the classic or acute form of the disease is by far the most common, and that's what we are going to discuss today. Animals that present with the classic form of SRMA present primarily with cervical pain. And an animal with cervical pain may have a reluctance to rise or walk, may have a stiff gait. They may have a hunched posture with their head held low. In addition, animals with SRMA will frequently have fever. They may be lethargic and have a reduced appetite because of the fever and the pain they are experiencing. But the disease does have a waxing and waning course. So they may have bad days and good days. Unfortunately, the good days don't mean that the disease is resolving. It's just, again, the waxing and waning course that we can see. And again, one other specific thing about the classic form of the disease is these animals do not have neurologic deficits aside from the cervical pain that they manifest. And here I will show you a brief video of a dog diagnosed with SRMA. So here we're putting the dog through range of motion, and hopefully you can appreciate the animal's head is held low, and it's very, very reluctant to move its neck. So the dog would rather move its whole body than move the neck from side to side. And in general, the posture is, again, with the head hung low and very reluctant to move the head and neck. There was a study that just came out this year looking at fever in young dogs. And I found it very interesting because it was quite pertinent to dogs with SRMA. So they retrospectively looked at medical records of 115 dogs less than 18 months of age that had a fever, in this case defined as a temperature greater than 102.5 degrees Fahrenheit, for which they found a definite cause for their fever. And you can see in the pie chart listed here that by far the most common category of disease was non-infectious inflammatory disease, with 79% of the dogs having that. 17% they did diagnose an infectious cause, and then there were 4% had other things, neoplasia and other associated disorders. Interesting to this discussion is of those dogs that were diagnosed with non-infectious inflammatory disease, 60% of those were diagnosed with SRMA. Therefore, I think the take-home message from this study is that SRMA is a very common diagnosis in juvenile dogs with fever and should be considered part of the differential diagnosis for a young dog that presents for a fever. SRMA, we think about as being a disease of the nervous system, when in fact it is actually a systemic disease. So in SRMA, we do see evidence of inflammation in other body systems or in other parts of the body. If you do blood work and you check a blood count or a hemogram, oftentimes we'll see inflammation there with an increase in the white blood cells, the neutrophils, in the majority of cases. And we oftentimes look at the age of the neutrophils to help us in terms of the cause of the inflammation. And with SRMA, usually we're seeing mature neutrophils, and it's not shifting back to the immature form of the cells, although sometimes immature cells can be seen. And again, I think to highlight the fact that it is a systemic disorder, there is an association between SRMA and another immune-mediated inflammatory disease, which we call immune-mediated polyarthritis, in which animals can also present with a very stiff gait, and it's due to inflammation in multiple joints in the body. And there's been studies of dogs looking at dogs who were primarily diagnosed with immune-mediated polyarthritis. And in those dogs, a portion of those dogs that underwent CSF analysis were diagnosed with SRMA. And conversely, in studies of dogs with SRMA, those portions of dogs that underwent joint taps could be diagnosed concurrently with IMPA as well. So again, these two disorders can occur concurrently. And also we can see other inflammatory signs or evidence of systemic disease. The lymph nodes can be enlarged. We can also see protein loss through the kidneys, which can be a manifestation of systemic inflammation. And similar to other inflammatory disease, SRMA is diagnosed based on the findings of CSF analysis. And the hallmark of SRMA is a marked increase in the neutrophils in the cerebrospinal fluid. This image here is actually a slide from a microscopic evaluation of CSF from a dog with SRMA, and those are all the predominant cell type there are neutrophils. Typically, the cell population is quite low, so we'd expect to see maybe 1, 2, 3 cells within that field as opposed to the many we are seeing in this image. We're always concerned about infectious causes, even though they're not common, so we oftentimes look closely for infectious causes, and in the case of SRMA, no infectious cause will be identified. We will oftentimes follow up with infectious disease testing just to make sure that there is no underlying infectious cause, and we may do bacterial cultures of the CSF. We can do testing to look for what are considered vector-borne diseases. Those are typically the tick-borne diseases. We can look for protozoal disease. We can look for fungal disease. And in instances of SRMA, all those tests will be negative. Recently, people have begun looking at serum C-reactive protein in the diagnosis and management of animals with SRMA. And C-reactive protein is what's called an acute phase protein, and it's an indicator of systemic inflammation that can be measured in the blood. And studies have shown that concentrations of the C-reactive protein are markedly elevated in SRMA. And it has been compared to levels that can be seen in other neurologic diseases, including other causes of encephalitis, epilepsy, disc disease. And it has been shown that levels of C-reactive protein are markedly elevated in SRMA and not so in those other diseases. And the elevations we see with SRMA are similar to what would be seen in an animal that has sepsis or a bacterial infection of its bloodstream. So again, pretty significant levels that we can see in terms of the elevations. And we can measure C-reactive protein serially, so take multiple measurements during the course of treatment, and it can be helpful in monitoring disease because studies have shown that the levels of C-reactive protein actually parallel the changes in the CSF cell count quite well. So in the past, we used to say to monitor disease, we would have to repeat the CSF tap to see that the cell count was indeed going down. Now that we know that the C-reactive protein can mirror what we're seeing in the CSF, we have a less invasive way of getting a relatively good idea of what's going on with respect to the nucleated cell count in the CSF. Such that if we have an animal that has elevated C-reactive protein levels, even if the clinical signs have resolved, we suggest that that animal continue with its immunosuppressive therapy. Unfortunately, normal values of C-reactive protein do not exclude the possibility of future relapse. So it would be nice to be able to use this to determine whether animals would relapse in the future. And the information that we have to date tells us that it is not helpful in that regard. SRMA is treated with corticosteroids similar to MUE, and we typically will use immunosuppressive doses of steroids and start the animal on a high dose initiated for usually a 2 to 4 week time, and then the dose is gradually tapered, usually every 4 to 6 weeks. So what you can expect then is that the total duration of therapy is often 6 months or longer. And we don't want to stop treatment too soon or taper too quickly because there is information to suggest that inadequate steroid dose, so not treating long enough or not treating with high enough doses, can lead to the development of the chronic form of the disease. And with the chronic form of disease, we actually can see neck pain with neurologic deficits. And fortunately, animals do respond quite well to this immunosuppressive doses of steroids. So we do see an excellent response to steroid therapy, but unfortunately, relapses are possible and can be quite frequent as the drug is tapered or discontinued. So we will use other immunosuppressants, namely those other immunosuppressants that we also use for MUE, for cases in dogs that prove to have chronic or refractory disease or are having unacceptable side effects from the corticosteroids. So what I'd like to share with you for the rest of the time now is some results of a study that we did here looking at the clinical characteristics of steroid-responsive meningitis arteritis in a population of dogs in North America. And this was done primarily by one of the neurology residents here, Dr. Lau, who received the Clinician Scientist Fellowship from the AKC Canine Health Foundation to do this research. So she performed this research under my direction. And the main aim of the study was to characterize SRMA in dogs in North America. As I mentioned previously, the majority of the work has been performed in Europe, so most of the information we have has been dogs from out of Europe, so we wanted to compare what has been published to a population of dogs in North America. And choose particular things that we are interested in is whether to explore whether breed differences exist in the clinical disease course and treatment response, and then also to examine quality of life in animals with SRMA. And the information I'm going to be sharing has not yet been published. So what we did is we retrospectively studied dogs diagnosed with SRMA. And we had two populations of dogs. One were dogs that presented to the Veterinary Teaching Hospital here at NC State between 2003 and 2017. And the other population was those identified through a survey on SRMA that was performed by the AKC Canine Health Foundation. For us to include the dog in the study, it needed to have classic or characteristic clinical signs, including a history of neck pain with no other neurologic deficits. And it did have to have a CSF tap performed to definitively diagnose the disease and have the classic changes that we expect with the neutrophilic inflammation and no identifying infectious cause. And the animals had to respond to treatment with corticosteroids, which is expected with SRMA. So based on that inclusion criteria, we had 61 dogs in the study. 29 were from the AKC Canine Health Foundation survey, and 32 were from our population here at NC State. With respect to the dogs that we had involved in our study, the median age of all dogs in the study was 8 months. They were as young as 2 months, and we had one dog that was as old as 81 months. Although that dog was an outlier, and we look at the general age of dogs, 95% of the dogs in the study were 2 years of age or less. And I think that is something important to remember, that occasionally we may have a dog that's a bit older than that, but this is primarily something that we're going to focus on in dogs that have signs and are less than 18 to 24 months of age. With respect to the dog's sex, we had a slight increase in males over females, but nothing significant. Both sexes can be represented with this disease. And the most common breeds that we had identified in our study were the Beagle, Boxer, the wire-haired Pointing Griffon, Bernese Mountain Dog, and Golden Retriever. And you can see in the colors denoted in the breeds is the dogs that were in the AKC Canine Health Foundation survey are in blue. The dogs at NC State were in gray. So there were several breeds, or a couple breeds in particular, that were interested in this and participated from the AKC Canine Health Foundation. And I think that was quite interesting because although Golden Retrievers have been reported to have SRMA in the past in the literature, it's not a breed that is commonly mentioned as one that's being predisposed to the disease. And to the best of my knowledge, the wire-haired Pointing Griffon has not been represented in previous studies on SRMA. Physical finding in our dogs, again, all had neck pain and lethargy, as are common with the disease. And associated with that, a reluctance to rise or walk, a stiff gait, reduced appetite, crouched posture, and tremors primarily can be attributed to pain. And muscle fasciculations, we can oftentimes see in animals that are tensing their muscles because of discomfort. 2 of the dogs in our study were concurrently diagnosed with immune-mediated polyarthritis. and we look at the temperature, I think this is something interesting as well, is that a vast majority of animals did have a fever diagnosed by a temperature greater than 102.5, and almost 40% of those dogs had, we would consider a quite significant fever of over 104. The highest temperature was in greater than 106. So these dogs do tend to have an increase in their temperature, and it can be quite dramatic. However, a quarter of the dogs presented with a normal temperature. So again, because this disease can wax and wane, they may not be febrile, particularly at the point when the temperature is taken and when they're presenting to a veterinarian. So all these dogs did have CSF analysis performed. And just in terms of the normal values, normal CSF is relatively low in cellularity, so we'll normally see 0 to 5 cells per the volume that we look at, which is a microliter. Of those 0 to 5 cells, usually none of those are neutrophils, so they usually tend to be other inflammatory cells, predominantly lymphocytes. And we also measure protein concentration in the CSF, and usually the protein is 0 to 25 milligrams per deciliter. As I mentioned, one of the characteristics of SRMA in terms of its diagnosis is a marked increase in neutrophils in the CSF. And in our dog population, you can see that the median value there was 735 cells per microliter, so pretty dramatic. And one dog in particular had a value almost of 8,000, so that is quite elevated cell count in the CSF. And of those cells, they were again predominantly neutrophils. Associated with this marked inflammation and neutrophilic inflammation, we can see an increase in the protein in the CSF as well. In the graph on the bottom, it just depicts the number of nucleated cell counts that we can see. So we usually consider 100 cells or greater marked inflammation, and 75% of the dogs in our study had what we would consider marked inflammation. 44% of the dogs had we would consider extremely marked inflammation with cell counts greater than 1,000 per microliter. So again, quite significant inflammation we're seeing in the CSF. Some of these dogs will undergo MRI, and you can find some abnormalities in the MRI, but the MRI findings are quite nonspecific, and in my opinion, really don't help in terms of the diagnosis. So I have here an MR from a dog with SRMA, and we're focused on the cervical spinal cord, and the head is to your left, and the tail would be to your right. The image on your left-hand side is an image before contrast is given, and the image on the right-hand side is after an intravenous contrast is given. So if there's anywhere where there is inflammation and there's a problem with the normal integrity of vessels, this contrast will get out of the blood system. We give it intravenously, and it can be picked up in other tissues. So the red arrows, if you compare the image on your left to the image on the right, you can see the additional white kind of outlining the spinal cord, and that's demonstrated by those red arrows, and that's showing some meningeal inflammation or contrast enhancement. And the blue arrow is actually showing some inflammation or contrast enhancement in the muscles around the neck. So we can see some abnormalities, but again, they're relatively mild and relatively nonspecific, and some animals actually will have normal MRIs. So again, the hallmark of diagnosis is definitely CSF analysis. Treatment does consist of corticosteroids. 100% of the dogs in our study did get steroids, and the dosage varied. So about half of them got what we would consider high immunosuppressive doses. And when we did immunosuppress them, the median duration of that immunosuppression was about 3 weeks. About 50% of dogs got a little bit of a lower dose, which we would consider in the anti-inflammatory range. And a small percentage of dogs did get a second agent. And of those second agents, cytarabine or cytosar was used most commonly. One dog got cyclosporin, one dog was treated with mycophenolate, and one dog was treated with flufonamide. And all the dogs did respond to treatment with resolution of the clinical signs. So again, it's usually not a concern about the dogs responding to the treatment. It's a concern about the dogs remaining in remission after that response. because relapses do tend to be common with this disease, and unfortunately, multiple relapses can occur. The published relapse rate is 16 to 32%. So approximately, we say approximately a quarter of dogs will suffer a relapse. And our study actually was much higher than that. 47% of dogs had at least one relapse. And some dogs have multiple relapses. We had 5 dogs in our study that had actually more than 4 relapses within the time of the follow-up of the study. And as I mentioned previously, there is not a way currently for us to predict what dogs will relapse. So what we tend to do is we tend to recommending treating them with an appropriate dose of immunosuppression for an appropriate period of time, and then tapering their steroids quite slowly. We monitor as we taper for recurrence of signs, and we can use C-reactive protein levels to look for, as an indirect method of looking whether inflammation remains in their cerebrospinal fluid, or CSF. One of the purposes of the study was to see if breeds tended to respond differently to the disease with respect to clinical signs or clinical course. And we actually found no breed differences within the study. We looked at clinical manifestations of disease, including the age at onset of disease, the severity of clinical signs, the findings in CSF. We looked at how they responded to treatment, how long it took for them to get to remission, whether they relapsed and how frequently that occurred. And we found no difference among the breeds. Although I should say that each of the sample sizes, so each of the breeds we looked at, had a relatively low number of dogs included, somewhere between 6 and 12. So the conclusions we can draw from this are limited somewhat by our small sample size. And again, I mentioned another one of our goals was to look at quality of life in these dogs, because this is a facet of SRMA that hasn't previously been explored. And concerns were brought up in the initial AKC Canine Health Foundation survey that was performed on regarding SRMA. And from that, it seemed that pet owners and caregivers were concerned about the impact of SRMA on the dogs with respect to the physical effects of both the disease and the treatment. Effects on the dog's temperament from the disease, and then problems with their dog's ability to get back to work or activity. So if these dogs worked or competed, the disease did impact their ability to do those things. There's also an impact of SRMA on the caregiver, and these can be emotional, financial, and lifestyle. So what we did is we did an online survey, which we sent to all owners of dogs that we had recognized in the study, and we got a response rate of 85% return of the surveys. And one thing that came out of that survey is that treatment-related adverse effects are quite common. And you can see here a list of the adverse effects that were reported with some frequency. The most common side effects that we see with steroids are increased water consumption, increased urination, increased appetite, and those were seen quite often. Dogs will pant on steroids because of their increased appetite. They can gain weight. They can have change in their coat, a pot-bellied appearance. They can be predisposed to other infections. So you can see a large percentage of dogs did suffer from adverse effects associated with those. We asked whether the adverse effects were present, and we asked owners whether they considered those severe. And the 3 adverse effects or side effects that owners thought were significant in terms of their severity were increased water consumption and urination, increased appetite, and then a thinning of the hair coat. We asked owners to score their animals' quality of life based on a scale of 1 to 10, with 1 being poor and 10 being excellent, at different stages of the disease. So before diagnosis, during treatment, during remission, and since diagnosis. I think you can appreciate from this graph that the quality of life did go down considerably during treatment. And what we did find due to that is that there was a strong association between quality of life during treatment and the severity of adverse effects of treatment. So the quality of life during treatment wasn't necessarily because of the clinical signs of disease, which again oftentimes will resolve quite quickly after you start the treatment, but oftentimes due to the adverse effects of treatment itself. And this is the place where we saw one difference with respect to breeds. The wire-haired pointing Griffons were reported to have more treatment-related adverse effects compared to other breeds. So for some reason, they may be more susceptible to the adverse effects of corticosteroids. We don't know the reason why that might be. So in summary then, SRMA should be considered in any dog less than 2 years of age with a history of neck pain, lethargy, and fever. And you should remember that those signs oftentimes wax and wane. So even though the pain may be getting better one day, it doesn't mean, unfortunately, that the disease is resolving. And you have to follow over a longer course of time to check for that waxing and waning nature. And because of that waxing and waning nature as well, the fever will wax and wane. So the animal won't always have a fever when presenting to a veterinarian, but that does not exclude the possibility of the disease being present. Diagnosis is based on the results of analysis of cerebrospinal fluid, and we typically look for that marked neutrophilic inflammation. Treatment consists of immunosuppressant with corticosteroids. However, the optimum dosage and duration has not yet been established. We do know, however, that treatment is associated with adverse effects that do impact the quality of life of dogs, so I think that is an important area of research to try to optimize the dosage and duration and with a focus on minimizing adverse effects. The initial response to treatment is excellent, but relapses are common. We can consider monitoring C-reactive protein concentrations as an indirect measure of what's going on with the CSF. And dogs should be monitored closely for recurrence of clinical signs because that is difficult to predict. With respect to areas of future study, again, we still know very little about the pathogenesis or the cause of this disease, so we still need to explore potential environmental triggers and look further into the genetics of the disease, particularly because we know that there are certain breeds that are predisposed to the disease. I alluded a bit to things that still need to be better understood with respect to treatment, and that's the optimum dose and duration, and how best to use other immunosuppressive drugs. So perhaps by using other immunosuppressive drugs, we may be able to minimize or lessen the adverse effects associated with corticosteroids. With respect to outcome, monitoring remission is still a big thing to look at. And probably more importantly, because we have no way to predict this at this point, is some way to predict the likelihood of an animal relapsing. I would like to acknowledge, again, Dr. Jeannie Lau, who is a resident who worked with me on this study, Julie Nettifee, who's my research technician and really helps me with all the research that I do. Ashley Hershey was a student that we had working on this project with us. Dr. Rue is the statistician who was involved. And then Dr. Brown, Watkins, and Boyer, who were very instrumental and helped from the AKC Canine Health Foundation and from specific breed clubs in getting the word out and really helping us in terms of our data collection. And, of course, the dogs and all their caregivers for participating in this study. And I appreciate your interest, and I can be reached at that email listed below.
Thank you, Dr. Mignogna. I want to take this opportunity also to thank people who registered for this webinar for submitting some really great questions, some of which are going to be put into our website in a written form after the event, and we'll keep everybody posted about them. But I know tonight we're going to address a few of them, Dr. Mignogna. Some of the more frequently asked questions from the audience tonight were along these topics. Are there triggers for SRMA? You've indicated that there's more research to be done there, but what can you tell us about that? Is there an association between vaccination and SRMA? And after a diagnosis of this condition, should we or should we not continue to vaccinate our dogs? So can you shed some light?
Yes. So the question about vaccine comes up a lot with these immune-mediated disease. And by all means, we know in human medicine that vaccines can precipitate immune-mediated neurologic disease, the most common of which is Guillain-Barré syndrome. And there's the concern that vaccines can precipitate disease in our animals as well. However, to date, that has been looked at, and typically, if vaccines are to trigger disease, it's typically within a 6-week time span. So there was a study out of the UK, again, most of the research has been out of Europe, on SRMA in 60 dogs, and the specific purpose of the study was to look at risk factors of disease as potential triggers. And the things that they looked at, or they looked at the season, they also looked at vaccination, and they divided it up as to the time of vaccination. So had vaccines been given within the last 6 weeks or greater than 6 weeks. They looked at the environment, urban versus rural. They looked at the sex of the animal. They looked at the neuter status of the animal. And they looked at the breeds of the animal. And they found no increased risk of disease based on all of those factors except breed. So we know that, again, certain breeds are at higher risk, but vaccination didn't tend to increase the risk of SRMA, the environment of the animal, the sex or neuter status, or the season. So right now, the information we have does not say there's an association between vaccination and SRMA. Going back to MUE a bit, there was a small study on MUE, which looking at a lot of the similar things, associations with environment and vaccine status and at MUE. And that study as well did not find an increased risk of MUE associated with the timing of vaccines. So again, there's some basis from other species and some experimental work for us to be concerned, but to date, there's no evidence to prove that vaccines increase the risk of SRMA. So what do we recommend in our animals with immune-mediated disease, and this is SRMA and MUE and others, is what we recommend is we do recommend vaccinating animals that are at high risk or for vaccines that are legally required. So for instance, in North Carolina, rabies vaccine is required. And because of the significance of rabies, if an animal should were to acquire it, we do recommend vaccinating against that. For the other diseases that we vaccinate for, we take it on a case-by-case basis. And currently, or more recently, titers have become available to check to see if animals who have previously been vaccinated have reasonable titers to some of the diseases that we vaccinate against. So that's what we are oftentimes recommending for, is that vaccinate for the diseases where your animal is at great risk or that are required by law. And then for those other diseases, then it's perhaps worthwhile to evaluate their immune status by titers. And we do recommend vaccinating when those titers lapse below a certain level. Because in particular, I mentioned rabies and distemper. Unfortunately, those diseases can be or are fatal. Rabies is fatal and distemper can be. So the risk of contracting the disease in an animal that is not protected may be greater than the potential risk of SRMA being exacerbated by vaccination. And hopefully we'll do some more research in this area as well and have a much stronger idea of the association with it. But again, if there is a potential association, it's going to be over the short term, usually within a 6-week time span.
Great. But I want to thank you again for some great information tonight, Doctor.
Thank you. It's been my pleasure to be here.
Thanks, Dr. Mignana.